Here I'll focus on the female reproductive system, specifically with the physiology. So as I go through this lecture, my goal for you all is to be able to describe the three phases of the ovarian cycle as well as the uterine cycle. They're distinct, but they have obvious overlap. And as I'm going through them, consider where it is that estrogen, progesterone, LH and FSH are all going to have their peaks. So that'll be another key thing to bear in mind as I go. Just as we saw with the male reproductive system, it's going to be imperative that we understand the hypothalamic-pituitary-gonadal axis here. So it's going to review a little bit of what was covered with the male reproductive and with a lot of parallels with the adrenal gland as well, right? Because previously we'd seen the hypothalamic-pituitary-adrenal axis. So how do these negative feedback loops work? In that discussion, you'll be able to answer questions such as how is it that birth control methods or the most common forms of birth control methods such as the pill or certain hormonal IUDs, etc., how it is that they can function so well. What is it that they are mimicking? How is it that they are stepping into this negative feedback loop in the female reproductive system? Other questions just to kind of bear in mind as I go through what's going to trigger ovulation? And then why is it that the corpus luteum is going to secrete estrogen and progesterone? And those questions layer into the learning objectives, but bear those in mind as we go. So to kick off, let's take a look at the ovarian cycle first. So this is specifically referring to what is going on inside the ovary, as the name implies, okay? So there are three phases. You have the follicular phase, you have the luteal phase, and then the third is really a moment in time. It only takes 2 to 3 minutes for ovulation to occur, but that is going to be what's considered the third component of the ovarian cycle. And ovulation is going to occur mid-cycle. So about 10 to 15% of women actually have a 28-day cycle, but going by that standard, ovulation would occur right around day 14. So some women who are looking to become pregnant may calculate about 2 weeks after their first day of their menstrual cycle. This is literally referring to the growth of a follicle. A primary follicle will mature into what we call a Graafian or a mature follicle. And then at ovulation, a secondary oocyte, so it's not an egg, it's not an ovum yet, but what we term a secondary oocyte is going to be released. After ovulation, the female body then enters the luteal phase. This is termed this because the corpus luteum dominates. I don't want to spend too much time looking at this particular slide because I want to also be able to draw the parallels with the histology over a period in class next week. But essentially, you're going to see primary follicles, secondary follicles, tertiary follicles, and then you get to what's called the mature or the Graafian follicle. This is the follicle that is chosen, if you will, each month to release a secondary oocyte. So this is the moment of ovulation. We actually see that the lining of the ovary thins as a consequence of a spike in LH. So it's going to trigger an inflammatory response. So that's one of the things that's going to trigger ovulation. What's left behind, so the Graafian follicle, after it ejects the secondary oocyte, it actually morphs into the corpus luteum. So it becomes the corpus luteum. They are one and the same. And this corpus luteum is going to produce progesterone and estrogen all the way. So if a pregnancy or fertilization occurs, this corpus luteum will keep making those hormones all the way throughout the first trimester. If a pregnancy or fertilization does not occur, then we'll see that this corpus luteum degenerates. With ovulation, so the ovarian wall ruptures, it expels the secondary oocyte, and it does so with what we call the corona radiata intact. So the corona radiata, literally a radiating crown of cells that is going to surround the ovum. Okay, so the Graafian follicle is all of this. And then this is going to be what's actually released during ovulation. So it's the ovum along with the corona radiata. So should fertilization occur, the sperm actually have to penetrate through the corona radiata to make it to the ovum. This is ovulation caught in camera. So laparoscopic surgery of somebody, and they caught the moment of ovulation. So that's what it looks like. So the luteal phase is named because the corpus luteum is dominating. The Graafian follicle morphs into the corpus luteum. Again, it's going to secrete progesterone and some estrogen. So if no pregnancy occurs, what you see happening is that corpus luteum degenerates in about 10 days, and it turns into what's called the corpus albicans. So it's like a white scar. And then if pregnancy does occur, again, the corpus luteum is going to continue to produce those hormones, and that's going to be critical because it's going to produce a negative feedback on both the hypothalamus as well as the pituitary. So let's do a bit of comparison here between spermatogenesis and oogenesis. So with spermatogenesis, you're going to have 4 viable sperm, 4 haploid that are going to develop, and all are viable, all carry the same amount of DNA, all are perfectly capable of fertilizing an egg. On the female side, we're going to see that meiosis, right, two phases of meiosis, meiosis 1 and meiosis 2, is going to be frozen in different periods of a female's reproductive cycle. So at the end of meiosis 2, which is completed only if a sperm does penetrate the oocyte, only then do you finish meiosis 2. And what's produced is 1 functioning, 1 viable gamete, and 3 polar bodies. And what those polar bodies are, they basically disintegrate. They don't have any useful function. They do have a haploid number of chromosomes. So N is depicted here. So they're all going to have 23 chromosomes, but there's not enough nutrition, not enough cytoplasm in these secondary polar bodies to sustain them. If you consider once a zygote is formed, once a sperm has penetrated the ovum, it has a 7-day journey before it's embedded into the uterine lining. And during that journey, it's going to be really critical that it has enough nutrients, it has enough energy to sustain it. So these polar bodies wouldn't have that ability. So it's almost as though we are literally putting all of our eggs in one basket with meiosis on the female side, whereas on the male side, it's a numbers game, right? It's all about millions of sperm that are all working to make their way to the egg. There's a lot of information communicated in this one graphic. I think it's very useful. Just to break it down to begin with, let's just focus here on the follicle development in the ovary. So if you look at these different panels, they're representing different stages of a female's life. So this is actually before birth, and you can see the primordial follicles. This is infancy to childhood. Again, we've got the primordial follicles. They're sitting at 2N. Okay, so 46 chromosomes. And you can essentially think of the ovaries as being dormant, as being completely inactive during this phase. And then about each month from puberty to menopause, a primary follicle will mature into a secondary follicle, and lastly into a they've got a vesicular follicle listed here, but this is the mature Graafian follicle. You've got ovulation that's occurring here. And then you are seeing that the follicle morphs into the corpus luteum. And it has this note about the absence of fertilization and what happens with the corpus luteum degenerating if no fertilization occurs. Now, looking at the events of meiosis and how that plays into this. So meiosis 1 is completed by 1 oocyte each month, also in response to that LH surge. So we've seen an LH surge trigger an inflammatory response in the ovary that allows for the thinning of the ovary and the release of the secondary oocyte. We also see that the LH surge, luteinizing hormone, right, coming from the anterior pituitary, we also see that this surge triggers meiosis 1 to be completed. So you have this division going from 2 in to 2 daughter cells, both with in. So what is released during ovulation, the reason it's not an ovum, and I try to be very clear about that, is that it hasn't finished meiosis, right? So what is ovulated is a secondary oocyte, and it's frozen in metaphase 2. So I'll show a video later where you can actually see all the chromosomes lined up along the midline. It's really fascinating to see that, but that is only going to push on to the other phases of meiosis if a sperm penetrates. Okay, so seeing those events play out side by side, I think is really useful on this graphic. Okay, so the female hypothalamic-pituitary-gonadal axis. So hypothalamus, we know, is directly upstream of the pituitary, not separated as this picture would suggest. So you've got gonadotropin releasing hormone that is going to be released from the hypothalamus. It'll travel through the infundibulum, and GnRH triggers the anterior pituitary to release LH and FSH. In males, LH and FSH acted on the testes, and we saw that the FSH predominantly stimulated sperm production, whereas LH predominantly acted on the production of testosterone from the testes. It's very similar with females. So LH and FSH act on the ovaries, and then you have estrogen and progesterone that's going to be produced. So think for a second about where we've seen estrogen and progesterone so far. We know that the corpus luteum is going to produce estrogen and progesterone. And what that will do is it triggers a negative feedback on both the anterior pituitary as well as on the hypothalamus. So it's telling the hypothalamus, I have enough estrogen and progesterone. You don't need to send any more my way. So hypothalamus cuts back on its GnRH production, which in turn cuts back on the production of LH and FSH. We have seen that LH triggers ovulation. If fertilization has occurred, if there is a fetus or embryo in development, then the last thing you want is to have menstruation occur or to have another egg that's released. So we need to ensure that we stop that process. And that's really what the estrogen and progesterone is going to be doing here, is it's going to be preventing the release and the maturation of another follicle. So thinking about this HPG axis over the course of development, so before puberty, ovaries are going to secrete small amounts of estrogens, and those estrogens, just as depicted here, will kick back and say, and allow for only a small dose to be maintained. Now, as puberty nears, similar to what we saw in males, you see that the hypothalamus becomes less sensitive to those estrogen levels. So it starts needing or demanding that more is made. So that set point, it's homeostasis, right? So the set point for estrogen and progesterone is going to go up a little bit. And it's not an instantaneous process. It takes about 3 years till the first menstrual cycle. So menarche literally means arc, first month, the first menses. So if a female has their first menses or reaches menarche at 13, that means around the age of 10, their hypothalamus began to become less sensitive to estrogens so that they could make more, and they gradually increase estrogens in the blood. So I've already described this, but this is a clear visual that I think it does a nice job depicting it. It's a bigger graphic, and I've cut it in half to really zero in on this piece. So hypothalamus, here's GnRH, here's the anterior pituitary. You've got LH as well as FSH that's coming from this. Well, here is the LH surge that triggers ovulation. The follicle that's left behind morphs into the corpus luteum. And this corpus luteum, right, is going to pump out progesterone, estrogens, also inhibin, and all of those, the dotted line is showing a inhibition. So it's a negative feedback on the hypothalamus, negative feedback on the pituitary. So it will prevent another surge in LH. If the corpus luteum maybe wasn't functioning, or if it degenerated prior to second trimester and an embryo were developing, then you would see that the GnRH levels would go up, and you would have FSH and LH released. And it would be a risk for a spontaneous miscarriage. Now, thinking about how all of this plays in together is an important piece. So what you're seeing up here are those gonadotropin levels. So gonadotropins, that's the FSH and the LH. Down here, you're seeing the ovarian hormones, right? That's going to be our estrogen and our progesterone. Here is that ovarian cycle. So you see the follicular phase, you see ovulation, and you see the luteal phase. So just kind of getting our bearings here. And as I've alluded to a number of times, there's this significant spike in LH that occurs just prior to ovulation. There's a corresponding spike in FSH, but I tend to zero in on the role of LH a little bit more. Now, looking at the ovarian hormones, so you'll notice that progesterone levels get sky high in the luteal phase. So pro meaning for, gestation, pregnancy. So this is a hormone that is literally for pregnancy. So it only has a reason to peak or to spike if there could potentially be a fertilized egg. So only after ovulation do you see that progesterone levels are going to go up considerably. You see the corpus luteum that's going to be sustained during this period as well. Now, this picture is depicting pregnancy not occurring. So the corpus luteum degenerates, and as it does so, look what happens to estrogen and progesterone. So looking at this information, think about what change, what is the distinct fluctuation in hormones that triggers premenstrual syndrome in so many females. We know that many females experience water retention, experience cramping, experience headaches. What is going on hormonally during that period just before menses? And what's happening is it's estrogen and progesterone levels are tanking. It's actually that they're falling. A lot of people think that these levels are increasing, but they are declining significantly. And so that ultimately allows for the shedding of the uterine lining. So I've talked about LH a bunch. I thought it'd be worthwhile to just pause and make sure that we're getting all of its key functions. So here it is again, right? So surge in LH, it's going to trigger the completion of meiosis 1 in whatever follicle is most dominant. You're going to see an inflammatory response. It'll weaken that ovarian wall and allow for physical anatomical ovulation to occur. Luteinizing hormone, so that it's got that luteal piece in it, right? It also is going to help that Graafian follicle morph into a corpus luteum. And then the last thing it's going to do, right, LH is going to stimulate the corpus luteum to produce those large amounts of progesterone and estrogen. Uterine cycle, right? So we saw the ovarian cycle before, but what's happening specifically in the uterus? I think this is very intuitive if you think about what's going on. So you've got the days of the cycle here. Again, halfway is when ideally ovulation will occur. So we are going to see that the secretory phase kicks in after ovulation. And this is a period, so secretion, this is a period where you have glands developing at tremendous rates. You have a tremendous blood supply that's coming to the functional layer of the uterus. And it makes sense, right? Should fertilization have occurred, should there be an embryo in development, it's going to be important that that embryo has the blood supply and the nutrients that it needs to last, especially until that placenta begins to form, and more on that to come. Now, prior to that, you have the menstrual phase. Okay, so this is typically defined as day one of the uterine cycles at the start of the menstrual phase. Variations here anywhere from 2 to 7 days, depending on the individual. But menstrual flow, proliferative phase is when the lining, the functional layer, stops being shed and begins to grow and develop again. So proliferative phase and the menstrual phase are going to correspond with the follicular phase of the ovarian cycle. And then the secretory phase is going to correspond to the luteal phase of the ovarian cycle. So here it is, all lined up. If you can explain this to somebody, if you can describe why we see these peaks and these various gonadotropin and ovarian hormones, then you have a good grasp on how the female reproductive system works. So key take-home points are going to be, how does the negative feedback loop work? How does it ensure that a pregnancy is sustained if one occurs? I had begun this lecture also talking about birth control, right? Most birth control is either a combo of a synthetic estrogen and a synthetic progesterone, or it's one of the two. And given everything we've been talking about, what that's really doing is it's almost as though it's tricking the body into thinking it's pregnant. So a corpus luteum, the placenta, are both going to produce progesterone and estrogen. It's going to provide that inhibitory feedback on the hypothalamus and the pituitary gland. And as a consequence, you do not have ovulation occur. So that's why they're so effective, but it's basically just, it's playing with this hypothalamic-pituitary-gonadal axis.